To the classroom series. We have here Dr. RanadhirMitra sir. He is a consultant and head in Utkal Hospital in Bhubaneswar. So, sir is going to discuss how to approach a case of hyponatremia in the Neuro ICU. It's very tricky because there are a lot of differential diagnoses which come under it. So, sir is going to teach us how to differentiate and how to treat each condition. Over to you, sir.
Thank you, Dr. Sindhu. Uh, good evening, everybody. Today, I'll be talking about how to approach a case of hyponatremia that we commonly face in our neuro ICUs, even in general ICU. So, let's start. So, let us start with some clinical cases. Uh, there's a first case when a 80-year-old octogenarian presenting to the emergency with a history of heart failure and with confusion and weakness. On examination, the blood pressure was slightly elevated. The lab test that they had done, the sodium was 128, which was on the lower side, potassium was normal, blood urine nitrogen was slightly elevated, creatinine was normal. So the ear physician sends for urine sodium, which comes back to the 60. So what would be your next step? So you have a octogenarian who is presented with altered sensorium, with confusion and weakness. So definitely these are signs of hyponatremia, and the only thing that you need to know what is the cause and how to approach this case. So after the end of our discussion, we'll come back to these cases again and we'll know how to deal with these cases. This is a case 2 where a 55-year-old male presented to the ER with history of alcohol abuse and presently having swollen ankles and fatigability. Blood pressure was elevated and the lab test shows sodium of 130, potassium 3.8, blood urine nitrogen 30, creatinine albumin, creatinine slight on the higher side of 1.2, albumin on the lower side. Liver enzymes are raised. So how do you approach this case of a hyponatremia? And the next case where a 70-year-old male with a history of hypertension and chronic headache presents with weakness, confusion, and nausea. And on examination, there were a dry mucous membrane, poor skin turgor, BP on the lower side. Investigation shows sodium 128, potassium 4, blood urine nitrogen again 25, creatinine slightly raised 1.1, urine osmolality 400 raised, urine sodium is raised at 60. So these are three different cases where they have different backgrounds. The first one has a history of failure, the second one has a history of alcohol abuse, and the third one has a history of hypertension and chronic headache. And all of them presents with hyponatremia and symptoms of hyponatremia. So how are we going to approach all the three cases? So let us begin with the basic water and sodium physiology, just to refresh our core concepts regarding sodium and water, because at the end of the day, this is nothing but the imbalance between water and sodium. And mostly, if you ask any nephrologist, they will insist that it is basically a disorder of water physiology and not only sodium. So this is a diagram which shows how water is filtered into kidneys. This is the renal end, and this is the glomerular end, and this is the collecting tubule. And from here, it is collected to the renal pelvis and back to the ureter and etc. So you can see that in a normal case, 65% of the sodium is reabsorbed in the proximal tubule, and majority of the water is also absorbed along with the sodium, and some of the part of the water absorption take place in the collecting duct through the help of vasopressin. And this sodium absorption is majorly occurs in the proximal tubule, around 65%. Rest of the sodium is absorbed along the ascending limb, thin descending limb, and the loop of Henle. And this absorption of sodium takes place with the help of some kind of ports, which are either symport or antiports. Along with sodium, either there is an coabsorption of chloride and potassium, or there is an efflux of hydrogen ion. And water is mostly absorbed along with sodium in the proximal tubule, along the concentration gradient, and also along the medullary osmotic gradient, and here through vasopressin. So this is the action of the kidney regarding sodium and water consumption. Like I said, in the early proximal tubule, the sodium is reabsorbed through a transporter mechanism, and which where sodium is absorbed and hydrogen ion is actively excreted. And this is influenced by anti-natriuretic peptide and low dose dopamine. So any inhibition will cause prevention of sodium absorption in the early proximal tubule and cause natriuresis. This is through action of ANP. And on the basal side, where the sodium is reabsorbed with help of sodium potassium antiport, this is stimulated by norepinephrine and angiotensin. So any decrease in sodium will stimulate the reticular angiotensin system, um, and the last system, and this will activate this antiport and cause sodium reabsorption. On the thin ascending limb of the loop of Henle, you can see that this sodium potassium trichloride input is affected by furosemide or loop diuretics. So when you are using loop diuretics, they will inhibit this antiport and cause natriuresis. These are stimulated by vasopressin. This is vasopressin not only acts on the aquaporin channels but also act on this input as well, and which are inhibited by prostaglandins. So if you have any prostaglandin inhibitors, this input will be inhibited and this is called natriuresis. So these are simply to because later on when we will know the causes of sodium loss, so this diagram should remain with you forever regarding where is the action of on which part of the kidney there is action of these hormones. And in the DCT, again this is thiazide sensitive channel, that is sodium chloride is input or co-transporter, which is inhibited and causing loss of sodium. And in the collecting duct, through the action of ADH, you can see that sodium is reabsorbed along with the sodium aquaporin channels. The water is reabsorbed, and the sodium channels. There is a sodium channel which is actually acted upon again by arterial natriuretic peptide and amiloride, which suppresses the sodium channel and causes natriuresis. But mostly collecting duct will only deal with aquaporin channel where where water is reabsorbed with the effect of vasopressin. So talking of sodium, because we are talking of we'll be talking about the sodium this whole evening. So regarding sodium, it is a principal extracellular cation, and normally the total body sodium is 58 millimoles per kg. It is normally an extracellular cation between 135 to 145. Anything less than 135, we call it as hyponatremia. And the only thing is that whenever you are measuring sodium in blood, there are two ways. Either you measure it in a direct method where there is no dilution is used, and normally even with presence of other confounding factors, you can measure the true sodium. But if you are normally that we use in lab, there is a serial dilution technique, which is an indirect method where pseudo hyponatremia is seen. So what is pseudo hyponatremia? What is hyponatremia? True hyponatremia? What are the various kinds of true hyponatremia? We'll see it. So we'll just talk a bit about sodium and blood-brain barrier because this is important, because sodium normally crosses the systemic capillary membranes between the clefts of the endothelial cells. Therefore, whenever there is a plasma sodium, suppose X, it equalizes over time with the interstitial sodium because there is a free movement across the capillary membrane. So therefore, plasma sodium normally equalizes with the interstitial fluid sodium. In a blood-brain barrier, because of tight junctions between the food process of the astrocytes and the endothelial capillaries, because of this tight junction, sodium cannot permeate. So what can move is water only. So any abnormality of sodium, either the lowering of sodium or increase of sodium, will cause simultaneous change of water movement. That will cause a water movement across the blood-brain barrier. Now this normally this change in blood volume normally this change in brain volume due to sodium because of ingress or exit of water stimulates the osmoreceptors in the brain. These osmoreceptors are generally TRPV1 and TRPV4. These are vanillin member receptors, and normally when the sodium falls below 135, normally what we call as an hyponatremia, these osmoreceptors are stimulated, and in turn they lead to stimulation of postpituitary causing release of ADH, and they stimulate the thirst center in the hypothalamus. And when it is more than 145, ADH secretion is at the highest level. So this is about osmoreceptors. So normally we see that this water imbalance or these disturbances in sodium, these are regulated by both at the level of brain to osmoreceptors and at the kidney through various co-transporters, antipodes, and through aquaporin channels. So normally there are two basic mechanisms which the failure of which causes hyponatremia. One is the osmoreceptors. Normally when there is an decrease in body content of water, so they stimulate the osmoreceptors, which stimulate the thirst mechanism that I have already mentioned. And kidney will cause, if there is a decrease in body water, it will try to concentrate, or the reverse. If there is an excessive intake of water, or there is hemodilution, or there is volume expansion, then it will liberate, the kidney will excrete dilute urine. Now, suppose there is any cause which which will prevent these two basic defense mechanism to act, like any cranial pathology which prevents the action of osmoreceptors. So there is a lack of thirst. So even though with increasing hyponatremia, the thirst mechanism do not act. So this in turn leads to vicious cycle. Similarly, if there is any cause where the kidney defense mechanism is inhibited, like the normal action of kidney is to produce dilute urine in presence of volume expansion, but the maximum that it can do it can do is 1 liter per hour of maximum dilute urine. But suppose you are taking the intake is higher than that, then it will cannot produce more dilute urine. So in that case, like in case of schizophrenia leading to primary polydipsia, or you are taking more of a solute, and solute intake is less in case of chronic alcoholic addicts, which we call as which are like typically in beer drinkers. So they eat very little. Mostly they live on alcohol. So in those cases, the urinary concentration cannot happen because low solute, or the water liberation is low from kidney. So in those cases, hyponatremia will occur. So remember one thing: the whole thing is about two things. One is that normally this defense mechanism will work of kidney. The kidney defense mechanism will work whenever there is a either a volume expansion or volume contraction. They do not directly. The first response is not because of lowering of sodium or increase of sodium. It is because either of volume expansion or volume contraction. So many causes of hyponatremia, like hypovolemia, medications, cortisol deficiency, nausea, pain, and stress, are reversible, and and because in those cases, normally we'll see that the pathology is not because of suppression, but the pathology is something different. And urinary excretion of sodium, like I already said, it is independent of plasma sodium. More depends on volume expansion or volume contraction. So therefore, in SIAD, where there is euvolemic, so there is no response to saline treatment. Unlike in cerebral salt wasting, where there is volume contraction. So acute changes on serum sodium, normally what happens is whenever there is a change of water content in the body of around 3 ml per kg, it will cause a change of serum sodium around 1 millimoles per liter. Maximum dilute urine that is produced whenever there is an increase of sodium by more than 2.5 millimoles per liter per hour. So what are the changes or consequences of changes in sodium? So whenever there is extreme hypotonicity, there is rupture of cell membrane by cell swelling, and whenever there is increase in hypertonicity because of either lowering of serum tonicity, and there will be egress of water or loss of water, and that causes breaks in DNA and leading to apoptosis. So normally how the cells adjust in the brain, normally over time they start accumulating solutes, organic solutes like glutamate, taurine and bioinositol. In cases of hypotonicity, there will be release of osmolytes from these cells through volume sensitive pathways. So these are actually the first kind of osmotic defense through the help of astrocytes, where they will cause immediately leading to taurine transfer. That is, start returning taurine in presence of hypotonicity. Because in presence of hypotonicity, there will be cell swelling, which can lead to cell rupture because of rupture of cell membrane. So in snapshot, this would be what it would look like, how the extracellular fluid and intracellular fluid changes. Normally in the top part, you can see that the extracellular fluid and intracellular fluid remains same, almost in equilibrium across the plasma membrane. But whenever there is a hypotonic hyponatremia, so there is one difference between tonicity and osmolarity. Tonicity is the ability to draw water across a semi-permeable membrane based on the type of molecules that are present in the plasma, and the amount of solute that determines the osmolarity. Now, whether they can draw water or not does not matter. Only the presence of solute itself will constitute how we will calculate the osmolarity. If they do not draw water, we call it as ineffective osmoles, like urea, because urea cannot draw water because it will equilibrate. It can pass freely through semipermeable membrane and it will equilibrate. So it is an ineffective osmole. While sodium the glucose, these are mannitol, glycine. These are all effective osmoles because they can draw water. So in hypotonic hyponatremia, so whenever there is a decline in sodium, so there will be that will lead to swelling up of cells because of there will be drawing of water into the cells. So there will be increase in both intracellular and as well as extracellular fluid because fluid will move freely from the interstitium into the intravascular space. So both there will be increase in fluid in extracellular as well as intracellular fluid, intracellular space. In hypotonia hyponatremia, due to in the presence of essentially normal sodium stores. So the in cases of SIADH, when there is secretion of ADH, the sodium content in the body remains same, but because of accumulation of water through the action of vasopressin, there will be increase in both intracellular and extracellular fluid, but the amount of sodium remains same. In case of you can see in the next part, you can see there is a hypotonic hyponatremia when there is an hypoosmolarity because from renal failure, the sodium is in fact there is an inability to retain sodium. There might be a sodium loss, so there can be hyponatremia. Hyponatremia also there is difficulty in excreting dilute urine. So there is both increase in vascular space and interstitium as well as there is loss of sodium. So but the sodium less is less in compared to the volume expansion. That is hypotonic hyponatremia. And so these are some of the ways I will discuss only with hyponatremia today. So these are some of the methods in which there is hyponatremia. As we now suppose there is a case of hyponatremia, how are you going to deal with it? So this is a clinical part. So first of all, like in any case, we will first of all see whether the hyponatremia that the patient has presented is severe enough to assess for a assess if there is a role of securing airway or not. But if the patient is severely symptomatic like throwing seizures, obtunded, so we have to look for ABCD like any other emergency case, because if the sodium level is less than 125, that is severe hyponatremia. Mild hyponatremia is between 135 to 145, moderate is between 125 to 134, and severe is less than 125. So there can be confusion, seizures, and coma. So in those cases, you have to first of all look for ABCD. In step 2, in the next step, what you will assess is serum osmolarity to rule out pseudohyponatremia. Because in pseudohyponatremia, the osmolarity remains same. The formula for osmolarity is 2 times sodium plus blood urea nitrogen by 2.8 and the serum glucose by 18. So pseudohyponatremia is caused by those cases where there is high triglyceride or high proteins. Normally, when the serum protein exceeds beyond 10 and the triglyceride is more than 1500, there is definitely a case of pseudohyponatremia. And in those cases, the simply serum osmolarity will come back normal and you have a hyponatremia. So you will and the triglycerides, so the proteins are raised. So you will think of pseudohyponatremia. And then after looking for osmolarity, either it will be normal osmolarity or hypoosmolar. It cannot be, and it can also be hyperosmolar. In hyperosmolar, normally there are, like I said, urea, like I said, mannitol, dextran, glycine, and glucose. If they are increased, then it can cause hyperosmolar hyponatremia. Because of dilutional effect, they have decreased sodium, but and because of drawing of water into the intravascular space, there is hyponatremia. And hypotonic hyponatremia is a true hyponatremia, where there is there might be a definite decrease in body sodium. So that is a true hyponatremia when there is a decrease in body sodium. The second is to measure urine osmolarity. If there is an normally what is the response of kidney? If there is there is a volume contraction or there is hypoosmolarity, then there will be stimulation of osmoreceptor, there will be stimulation of kidney to the RAS system, and there can be retention of sodium and excretion of hypoosmolar urine or concentrated urine. Dilute urine. In case of hypovolemic hyponatremia, and in those cases there will be dilute urine. Suppose there is a volume contracted hyponatremia. So in those cases, normally the urine will try to retain the volume, and in the cerebral salt wasting, the volume will be concentrated. The urine will be concentrated. The urine will be concentrated because the kidney, in case of the kidney, there will be loss of sodium as well as water. But in parts of the kidney where there will be action of actinonatriuretic peptide or brain natriuretic peptide. In other parts, there will be retention. So urine osmolarity will be definitely on the higher side and urine sodium will be either on the higher side or on the lower side. In case of cerebral salt wasting, because of natriuresis, there will be loss of sodium in the urine, so sodium will be the higher side. And and in case of SIADH, because of action of vasopressin, because of volume will be removed from the kidney, so sodium will be on the higher side again. So low sodium will occur in case of cases where there will be true hyponatremia, where the total body sodium will be on the lower side. And at the same time, the kidneys are working just in the adjusted manner. So we'll come in the detail in the following sections, and then we'll look at the volume status. Volume status will look in the history itself. If the patient gives history of repeated vomiting, and then the patient is on chronic diuretic use, then there will be a depletion of the volume. And then you look at the skin turgor, you look at the mucous membrane. They can give you an indicator towards the volume status. And the third is if you have a focus or the bedside ultrasound machine, you can look at the inferior vena cava, the diameter, and the collapsibility. So that will give you an indicator of volume. So first we look at the ABCD. Next we look at the serum osmolarity to find out about whether there is pseudo hyponatremia or normo-osmolar hyponatremia. Then we'll look into urine osmolarity to find out whether there is hypoosmolar, whether urine is concentrated or not, and also at the urine sodium. Next, we'll look at the volume status. Then, along with that, we'll do other tests. Like we'll look for the lipid panel to find out pseudohyponatremia. We'll look at CBC. Then we'll look at fractional excretion of sodium in uric acid. These are done at some cases. And then we'll look at other causes, like we might need to do a thyroid function test to find out the presence of any other case like hypothyroidism. We might look at random serum cortisol to find out our adrenal function test, and also at the LFT to find out if there is a case of cirrhosis or a chronic liver dysfunction. And then at the last we'll look for correction of hyperosmolar hyponatremia, because in case of hyperosmolar hyponatremia, sometimes because of correction there can be a fall of serum sodium. During hyperosmolar hypernatremia, this is an hypernatremia. So during hypernatremia correction also, there might be rapid fall of sodium leading to hyponatremia. In those cases also you have to look at it. And normally if you have a hyponatremia, look at serum osmolarity. Look at if there is like I have already said, in case of isoosmolar, it is always pseudo hyponatremia because of rise of lipid or protein. In hyperosmolar hyponatremia, the hypotonicity, like I've said, it is caused by mannitol, glycerol, glycine, and sugar. This is a hyponatremia that we are concerned with, because this is a hypoosmolar hyponatremia is the commonest form of hyponatremia that we get in ICUs, and the commonest cause is SIADH. So in hypoosmolar hyponatremia, where there is a definite decrease in osmolarity, then we look at the urine osmolarity. If it is less than 100 or more than 100. If it is less than 100, that is the urine, the kidney is not able to concentrate urine. Then that might be a case where the total intake is higher than the capacity of the kidney to concentrate urine. So because there is a hypoosmolar hyponatremia, the kidney will try to dilute the urine. So normally if the urine is diluted, so it can be because of simply beerpotomania, where there is low solute, or because hypogenic polydipsia. So this is on the expected lines. So but if the urine is throwing concentrated urine, in case of hyperosmolar urine in presence of hypotonic hyponatremia, or then we have to look at volume status. So if the patient is volume depleted, and then the urine is, if the patient is volume depleted, volume contracted, normally there will be the kidney will try to return volume and sodium. So the urine sodium is less than 20, and this is a normal action of kidney. This happens if there is external loss of sodium and fluid, like in vomiting, diarrhea, and burn. Now, in presence of hypovolemia, because there is a volume contraction, the kidney will try to retain urine, retain volume, and retain sodium. And but instead of returning sodium, if the urinary sodium, if you find on the higher side, that is abnormal. That means there is some problem. Either the patient is using diuretics, or there is a cerebral or renal salt wasting, or there is a steroid deficiency. There is mostly adrenal insufficiency leading to mineralocorticoid deficiency, which can lead to loss of action of both, and it can cause a loss of sodium. The sodium will not be retained. So, and next is when there is an hypervolemia in case of hypotonic hyponatremia with a raised urine osmolarity. So in those cases, if you find normally if there's a hypervolemic state, suppose a patient look bloated up, patient is swollen, and then and you find that the urinary sodium is on the lower side, because in these cases, what happens is that they are actually in a volume contracted state. The only thing which makes them bloated is the presence of fluid in the interstitium. So normally this happens in congestive cardiac failure, cirrhosis, etc. So in those cases, normally the kidney, because of volume contraction, will try to return water and sodium. Therefore, the urinary sodium is on the lower side in these cases. So urinary sodium is on the lower side in case of hypervolemia. Then it is a congestive cardiac failure, cirrhosis, or nephrosis. If the patient is bloated up and but the urinary sodium is on the higher side, that means that the kidney is not functioning properly. That is in acute or chronic kidney disease. Now, in case of euvolemic hyponatremia, normally I have told you this is the commonest case in case of our clinically that we see, that is SIAD, the syndrome of inappropriate ADH secretion. And but before SIAD is a diagnosis of exclusion. We have to rule out the presence of hypothyroidism and steroid deficiency, and if there is any drugs which causes it. So the major etiologies of an ICU, like I said, these are some like we have discussed everything. The only thing is that this is the commonest cause of hyponatremia in ICU, that is euvolemic hyponatremia, that is syndrome of SIAD. Now this is one of the article that I have taken up, which was published in NEJM in 2023, where they have discussed about SIAD, and among the many pathologies you can see in cancer, mostly where there is ADH secretion, ectopic ADH secretion, that is mostly in small cell carcinoma or in olfactory neuroblastoma. In pulmonary condition, lung condition, which can cause ADH secretion, which are mostly any kind of pneumonia can cause, both bacterial and viral, and also observed during prolonged positive pressure ventilation. Then is CNS disorders which can cause ADH hypersecretion is like subarachnoid hemorrhage and post-pituitary surgery. There can be in subarachnoid in 56% of cases there can be SIAD, while in those following pituitary surgery in 35% of cases or one-third cases there can be SIAD. Then in drug related, mostly we are concerned with when the patient is taking antipsychotic medications like sedative serotonin reuptake inhibitors, and or patient is taking tegretol for some time, even in oxetol or oxcarbazepine also, SIAD happens. And in other causes like post-operative patients presenting with hyponatremia, mostly they are because of pain, stress, anesthesia, and this causes secretion of ADH for the post-operative. So in those cases there can be hyponatremia due to SIAD. Now, like I said, in antiepileptic medications, you have some carbamazepine, lamotrigine, oxcarbazepine, and sodium valproate. These are commonest antiepileptic medication which will present with SIAD. Now, the only thing that normally confuses us is what is the difference between SIAD and cerebral salt bursting. How to distinguish both the conditions. The only method, see, there are a lot of things which are given in literature, like the, the fractional excretion of sodium is greater on the SIAD and less in the cerebral salt bursting, or uric acid, fractional excretion of uric acid. Blood urea nitrogen is on the elevated side because of hypovolemia in cerebral salt bursting, while it is normal or low in case of SIAD. But remember, the only thing that can distinguish cerebral salt bursting and SIAD, one is volume, and secondly, a history of loss of volume preceding the onset of hyponatremia. These are the only two things that will help you to distinguish between SIAD and cerebral salt bursting. There should be a history of volume loss, and you can objectively show that there is a volume loss. These are only two things. And you should know how to distinguish because the treatments are radically different. In one, there will be volume, you have to give volume in form of saline, in another, you have to restrict volume in case of SIAD. So, if in case of SIAD, normally the first line action is to restrict the fluid. Normally, fluid restriction we keep it practically we keep it around 1.5 liter per day. And another method in which you can decide whether how to and how much to restrict is by a first formula, not FIRST, it is FURST, where there is an urinary sodium and potassium divided by serum sodium. If it is less than 0.5, you have to restrict the fluid up to 1 liter. If it is between 0.5 to 1, you can restrict to 500 ml. If it is more than 1, you can give fluid. You do not restrict any fluid. So normally, the problem with fluid restriction is that you cannot do it in case of subarachnoid cases of subarachnoid hemorrhage. Like I said, in one-third cases that will be SIAD. so you cannot restrict it in those cases. There is high chance of vasospasm. And secondly, it is also you cannot do it in case of other intracranial pathologies. There are some pathologies where you cannot dehydrate the patient. The next step is, first of all, fluid restriction is the first step, and second step is you have to give salts. So normally we give extra salt for if you have diagnostic case of SIADH, then you can give up till 2 to 5 gram per day. Normally we start with 3 gram per day, 1 gram 8 hourly, and increase it as required to maximum 5 gram. And this is also of a limited efficacy and contraindicated in cases where there is a high blood pressure, and in case of patients who have heart failure and other where there is sodium retention states. Then next is urea. Practically we don't use urea, I've never used, but there is evidence in literature to use urea for 15 to 60 gram per day orally. And then also is contraindicated in case of liver and hepatic failure, liver failure and kidney failure. The last is tolvaptan. Tolvaptan you can use in case of chronic hyponatremia, and in those cases, tolvaptan can be used, but the usage should be restricted within 30 days. FDA has not approved beyond 30 days. Normally, we start from 7.5 milligram per day and can increase it in the higher side. But remember, when you are starting tolvaptan for the first time, you can use tolvat on the starting dose of 7.5 milligram, because the incidence of rapid correction of sodium and osmotic demyelination are less in these cases. We are using 7.5 dosage per day. And then when you are using tolvaptan, you have to be very careful. You have to monitor sodium, because normally in those cases only osmotic demyelination happens because of unregulated or prolonged use of tolvat. So acute symptomatic hyponatremia is a medical emergency. So in those cases, normally we see if the patient is throwing seizures or patient is mentally obturated or low sensorium. In those cases, you can give straight away 2 vials of 3% NS, that's 200 ml, and quickly you can give it, and you can allow a rise of serum sodium to 4 to 6 milliequivalents, and rapidly over 4 to 6 hours you can allow a rise. And in the first day in acute hyponatremia, when the duration of symptoms are less than 48 hours, it is acute, and if it is more than 48 hours, we call it as chronic. In acute, you can go for a aggressive correction, which works miraculously and can stop seizures. And then you can slow the rate of the rise of sodium. In case of chronic symptomatic, where the symptoms have been more than 48 hours, you have to correct it at the best at 4 to 6 milligram per day. And in asymptomatic hyponatremia in hospitalized patient, you can simply assess volume status. You can, if it is decreased, you can give saline. If it is adequate, then restrict fluid if it is on the higher side. And in case of asymptomatic chronic hyponatremia, especially due to SIADH, you can go for, like I said, for treatment of underlying cause, or you can go for fluid restriction. In certain cases, normally you can increase of solute intake through increasing of sodium, protein intake, and you can also add Lasix. But recent literature which has been published in 2023 and 24 also, it has shown an increased mortality while using Lasix along with high solute. And you can use certain cases double demylination from 300 to 600 milligram per day. In case of those cases where the correction of hyponatremia, in case of correction of hyponatremia is for cases where there is correction is very fast, and if the serum sodium is rising pretty fast, then you can correct it. You can keep a check on that by using desmopressin nasal spray. But normally what we practice is, normally 4 to 6 hours we send sodium, and we keep the correction rate at less than 6 milliequivalents per day. So there are methods in which you can prevent a sudden rise of serum sodium by using vasopressin or desmopressin nasal spray if required. So this is basically how we will correct. Like I said, in case of severe hyponatremia, you can correct 4 to 6 if it is several hours. So you can correct it within 4 to 6 milliliter in the first 6 hours by giving boluses of 100 ml of 3% saline. And if it is within 48 hours, within hours of presentation, you can give it within 48 hours. You can give 3 times a day of saline, 100 ml of 3% saline, or you can give it continuous infusion as well. And if it is unknown, then you always, in case of unknown cases of hyponatremia, you have to assume that it is a chronic hyponatremia and go slow. So rapid correction can cause osmotic demyelination syndrome. It is a biphasic illness, and generally it autocorrects over time. So the basic pathology is a demyelinating brain lesion, where basically basis pontis the central pons is demyelinated, and also in certain cases you can get extrapontine demyelinations, which happens in basal ganglia region. There is non-inflammatory injury or death of oligodendrocytes, which leads to, and there is also loss of myelin with relative axonal swelling. This is a typical histopath with osmotic demyelination. The features are normally dysarthria, dysphagia, and quadriparesis, movement disorders, etc. And they can also progress to permanent disability and death. Normally, the patient can have a full recovery, but then it is unpredictable. Normally, there is initially the symptoms improve, then there is again a gradual onset of new neurological findings like quadriparesis and cerebral palsy over time. Therefore, it is called biphasic illness. Prevention is you have to know what you are correcting, whether it's an acute hyponatremia or chronic hyponatremia, and then you have to check for the correction, like I've already said. So I think to this I come to the end of the discussion. If you want to ask, I'm open to questions right now.
Thank you, Ranadhir. Thanks for that wonderful lecture, Ranadhir, about hyponatremia. Ranadhir, just you are talking about adding desmopressin while we are correcting acute symptomatic hyponatremia.
Yeah.
So how prevalent is that practice? Because we have been doing that regularly, but in practice, not many centers follow that. So, can you just throw some evidence on that aspect? Because as you can see, when you just start correcting the hyponatremia with 3% NS, rapidly the patient will go for water diuresis, and there will be a marked increase in sodium, and that's very dangerous during that phase of correction.
Yes. So normally, like right you have said, like there can be an diuresis when you are rapidly correcting hyponatremia. See, the most important thing is to keep and check on. You have to keep monitoring serum sodium. That is the most important thing that you can do, and also monitor for urine output. Now, suppose suddenly the urine output increases, and then you find that the serum sodium is corroborating with it. There is a sudden rise of serum sodium, and along with diuresis. That is the first point where you can add desmopressin. And I think that is how we do it. But I will tell you, it is not a very prevalent practice, because normally in most of the centers, what I feel is normally the serum sodium correction is done pretty slowly, uh, because of high fear of osmotic demyelination. So normally I also do not practice giving desmopressin routinely until unless I find that the correction is pretty fast.
Okay, so this practice I have just implemented in my institution, and it's really very helpful. And it's also very important because even if you give even in an chronic hyponatremic patient who is presenting with symptomatic severe symptoms with seizures, even if you give just 50 ml of 3% NS to just alleviate the symptoms, patient will land up in severe polyuria. The sodium might rapidly correct. So giving a dose of desmopressin either intranasally or orally or through right tube is the preferred technique where we can slowly correct the hyponatremia and it will be under control. Because once the patient start passing urine with water diuresis, even though you monitor sodium, by the time the report comes, the result comes, it's going to take a long time.
Yes, I
Okay,
agree.
Ranadhir. Thanks. Yeah, thank you for that wonderful lecture for an important and practical aspect of hyponatremia. Thank you for everyone who has participated in this wonderful discussion, and hope we can meet you in another classroom with another topic. Thank you,
Thank,
Ranadhir.
thank you, sir. Thank you, sir. Bye. Good night.